I'm Shannon Moreno, CLC specialist with Texas System of Care. This is our second episode of our podcast series on working with youth with intellectual and developmental disabilities. We continue our conversation with Michelle Garcia, clinical psychologist at Michelle Garcia, Psy.D and Associates in the Woodlands, Texas. So I'm wondering if you could talk a little bit about identity, for folks who have IDD, autism, various neurodevelopmental conditions. For some folks, perhaps that is very much a big part of that person's identity. It may even kind of be a separate cultural group. I know that with autism, some individuals very much prefer the person first language that you were talking about before, of like a person who has autism or living with autism. But some folks, prefer the identity first language of, they want to be referred to as I am autistic or I am an autistic, which, on the person first proponent side can kind of sound a little cringeworthy, but some youth, some individuals do want to identify that way, that's a big piece of who they are. But certainly that's not everybody. Other folks don't consider their disability to actually be a part of their identity. It's certainly a big part of their life and has an impact on their life, but kind of being part of like a cultural community, that doesn't necessarily ring true for that person. Can you speak a little bit to that, on ways that you've seen these kind of different views on how much a disability might be a part of a person's identity, and how can a clinician, because there can be such a big range on how individuals feel about this, how can a clinician be respectful and try to have those conversations and understand how the youth that they're working with feels?
So when it comes to identity, I feel that that's true with anything that somebody goes through in their life, whether it's a traumatic car accident, whether it's having a disability, whether it's infertility or divorce. I think anything that is significant for a person, you take into who you are and what you've been through, and that shapes your life, I think, in a lot of ways. And I think it's the same thing for people with disabilities. We can try to, quote, ignore the fact that somebody has a disability, but certainly their lifestyle and what the person goes through is going to be different, whether we want to look at it or not, than somebody without a disability. We're still not at that point where people are completely treated the same, whether it's in school or in the workforce. And so I think that completely ignoring it wouldn't make sense. But looking at certain individuals, they absolutely want to have people recognize that it's a big part of who they are. I can think of one person in particular we work with who is a huge advocate, and she goes to a lot of different conferences and is on a part of several committees advocating and talking about what it's like to have a disability. And she has often said that the individuals who work with her, the caregivers, need more training and to understand what her life is like and that it is different than their life. And so I think that for some individuals, it can be a huge part of what stands out for them about who they are. And, again, to that end, you asked about professionals. And I think that as professionals, we need to do a much better job of just asking the person, especially if they're able to tell us what is important to them, what do they want to work on for their goals, how do they want to be treated, and not as far as obviously respect. I mean, we need to respect everybody anyway, but as far as, what is it that makes them up? What is the most important part of their life and who they are? And I think just by asking those questions and starting any treatment with the person rather than the symptom or the syndrome or the medication or, the caregiver. I think if we start with a person, I think we're always going to be able to ascertain where that person is with their identity and how a disability impacts their life as well as everything else. And I think we'll do such a better job. I think there's such a problem, unfortunately. One of the things that we do is we will go to different doctor's appointments with individuals we support. We will go to school meetings. We will support them at work and in all aspects of their life, help them be a part of an art parade or what have you. And so in doing so, we interface with a lot of different professionals. And unfortunately, it's not all the same, and people are not always treated in that way. And so I can't tell you how many times I've been with a person at a doctor's office or am going with that person to a doctor I know will be respectful and look at the whole person because they have told me or their caregiver has told me about the experiences they've had up until then, about doctors not looking at the person face to face, but instead only looking at the caregiver, not even saying hello or how are you to the person, regardless of whether they're able to verbalize a response back. And so I think that there's just so much more training that needs to take place in all of the professional communities about how to work with people with disabilities and quite honestly without as well, but especially for people with disabilities so that they know how to do that. I mean, oftentimes, unfortunately, our traditional medicine approaches don't always work the same either for people with disabilities. They sometimes have different medical conditions that counteract how medications work or that cause more side effects in certain ways, like gastrointestinal side effects. And so we really need to be approaching it differently. There is even a few new panels through a couple of companies where they do genetics testing and based on that determine what psychotropic medications are going to help them with their psychological symptoms. And I think that's so beneficial because, again, we know that people with disabilities don't always respond the same way to medications and or to different approaches. But again, if we look at the person as a whole and we're starting there with that person, we're going to do a much better job with understanding what's important for them and with trying to figure out how we can best help them.
So it sounds like for a clinician to be very effective with this population, it's not only looking at that individual person that you're working with as a whole, like we've been talking about, but also looking at holistically their environment and the different environments they're going to enter into, the different systems that they're going to interact with, and having an awareness of within that specific system, within that specific, profession, whatever the case may be, if there's a lack of current awareness and understanding on how to work with this population, that's going to impact your client, and that's going to impact your client in a variety of ways, potentially medically, socially, emotionally. And so to not have that awareness brought into the professional relationship, into the clinical relationship, that it sounds like that's a huge missing piece.
It is a huge missing piece. We go out to see individuals in their homes and day programs and schools. And like I said, we'll go to doctor's appointments. And obviously most physicians, most clinicians don't get that opportunity. And so they miss the environmental piece. They miss, does this person live in a rural area? Do they live in a suburban area? Do they live in an apartment or a house? Do they have a caregiver who understands them? Do they have access to the things that they need when you're trying to drive treatment, when you're trying to help that person? And if you're not taking into account their entire environment and what goes on day to day between the hours that clinician or other professional is not with the person, then you're missing a huge piece, and you may make recommendations or drive treatment in ways that is not going to be effective, either because it may not be possible in that person's environment or for that person, or just because you may miss a significant factor that impacts them. And you mentioned holistic. If you look at some of the natural resources, so natural medicine and holistic therapists, and you look at some of the things that they talk about with environment, I mean, we know that our environment and our nutrition and all of those factors can make a difference in our etiology. And so if we're not looking at, for this person, for example, who has diabetes and needs to have, healthier foods to control the sugars and things like that, but doesn't have the funds to purchase certain foods that are recommended and doesn't necessarily have the education, or their caregivers don't have the education about what does that mean? What does eating healthy with a, diagnosis of diabetes, what does that mean? Or, where the person shops, or what they have around the house, or what their caregivers have around the house. It makes a huge difference as far as how treatment is going to be and how that person is going to feel.
And it kind of sounds like there's a need for just an ongoing assessment of, everything that's going on with the individual, everything within their environment, within their support network. It may not be enough to just at an initial appointment do a quick kind of checkbox style biopsychosocial, but you may need to revisit that over and over again as a clinician. Do you think that's fair to say that in your work you kind of maybe perhaps without noticing it, or maybe perhaps very, very intentionally, are you just continually assessing the environments of the folks that you're working with?
We are, absolutely. We go into the person's environment typically every other week to do just that. So we may do an initial thorough assessment and make some recommendations because we want to help them, but then we're going back out to tweak and change and support the person, empower them. Because without that piece, you can't take your traditional approach of, here, for lack of a better phrase, take two aspirin and call me in the morning kind of thing. You really have to say, okay, let's try this and let's see how it impacts the person and their environment. And you have to revisit every time, saying, especially in the beginning, meeting more often to see if it's going well. Is it able to be implemented? Did the individuals understand what was discussed in the very beginning when you did make recommendations? Providing more handouts, more information, more tangibles, because I think also sometimes practitioners will give information or recommendations and not write it down and expect that everybody's understanding what they're saying and going to remember it. But even sometimes we have caregivers who have disabilities themselves. And so when you have a caregiver with a disability and an individual with a disability, and the practitioner is expecting them to understand and follow information that may be too complex or not realistic in their environment, we absolutely have to reassess, and we have to reassess often in the beginning until things start to go underway. And we still need to reassess the entire realm of treatment, but less often as time goes on, once you have a good idea of what's working, what's not, and what is realistic.
I hope you enjoyed today's CLC podcast. If you have any questions on how to bring CLC initiatives into your local system of care community, please feel free to email us at info@txsystemofcare.org.